Good afternoon, everybody. Thank you for joining the webinar today. My name is Katie Habert, and I'm a policy analyst at the Council of State Governments Justice Center, and will also be your moderator for today's discussion. I want to thank our partners at the Addiction Technology Transfer Center Network and the Center for Health and Justice at the Treatment Alternatives for Safe Communities for co-sponsoring this webinar with us today. I'd like to briefly talk through a couple of housecleaning items about how the webinar is going to work. Anytime during this webinar, you can ask a question by typing it onto the Q&A panel on the bottom right-hand portion of your screen. We will keep a running list of the content-related questions that we receive and then ask the panelists to respond to the questions during the last segment of the webinar. We will do our best to get through as many questions as we can in the time that we have today. If you encounter technical or audio problems during this webinar, please call WebEx technical support at 1-866-229-3239. Please understand that there are some technical issues you may not be able to resolve, and for this reason we will be recording this event and we'll post it on our website at www.nationalreentryresourcecenter.org. We should have the webinar posted online early next week, and once it has been posted, we will email you a link to the recording. This is a snapshot of the Resource Center's homepage. We are constantly adding new content and resources to our website, and we send out a monthly newsletter that provides information about the latest research, funding opportunities, distance learning events, and other news about reentry. To sign up for the newsletter, please visit the link on your screen after today's webinar. Before I introduce our speaker for today, I would like to provide a bit of background information regarding this webinar. In our work with the Reentry Resource Center, we often hear that one of the most challenging aspects of a reentry program is effectively retaining clients in community treatment and engaging families. As we know, engaging clients who need treatment in community treatment after incarceration is extremely important, as it increases recovery rates and contributes to decreasing recidivism rates, both of which are obviously very important to the reentry process. As a result of these common challenges, the Reentry Resource Center, in partnership with TASC and the ATTC, will be bringing you a 5-part webinar series on client engagement in community substance abuse treatment. Today's webinar is the first part in the series, focusing on creating a strong foundation for effective connections to community treatment from incarceration. We hope you're able to participate in all of the webinars and participate in dialogue on how to effectively engage clients in treatment post-release. And again, if there are future webinars that you're unable to attend live, we will record all of them and post them on our website so you can view them at your convenience. I would now like to introduce our featured speaker for this afternoon. We are thrilled to be joined by Phillip Barbour, who's the Master Trainer for the Center for Health and Justice at TASC. Mr. Barbour has worked in the field of substance abuse counseling since 1990. He joined TASC in 1991 and has worked on a number of the agency's criminal justice programs. He is also a registered trainer with the Great Lakes Addiction Technology Transfer Center, which is part of a national network of centers sponsored by the Federal Center for Substance Abuse Treatment, which is part of SAMHSA. We are very excited to have Mr. Barbour with us today, and with that, I'm going to go ahead and turn it over to Phillip, who's going to say a few words about our co-sponsor organizations, and then we'll get into his presentation. Phillip?
Thank you, Katie. Welcome, everyone. I hope everyone is having lovely weather. I'm talking to you from Chicago, Illinois, and today we actually are close to 80 degrees and sunshine and no rain, and I couldn't be happier. So I hope the weather is good where you're at. Again, I want to thank you for joining our webinar this afternoon. One little quick housekeeping note, just so nobody's alarmed. I'm in a room that is behind a wall close to a fire door, and the thing that keeps the door from slamming is broken. So I have posted signs on the door not to let it slam behind you, but if you occasionally hear a loud bang, please do not be alarmed. It's only the door slamming. Unfortunately, it makes a very loud noise, but I thought I would mention that just so no one would feel surprised by it. So quickly, let me talk to you a little bit about the ATTC Network. Again, as Katie mentioned, I'm with the Great Lakes region. Now, the map that's shown here on the slide is a little hard to see, But as you can see, the country is divided up into 10 different regions. And I am in this orange region, the Great Lakes region here. And just to let you know, the ATTC Network is funded by the Substance Abuse and Mental Health Services Administration, and they serve a critical role in improving health in our nation. The mission of this network is to accelerate the adoption and the implementation of evidence-based and promising addiction treatment practices and recovery services. We want to heighten the awareness and knowledge and skills of the workforce that address the needs of the people with substance use or other behavioral health disorders. And finally, to foster a regional and national alliance among practitioners, researchers, policymakers, funders, and recovery communities. Now, in addition to the 10 regions that are on the map, there are 4 national focus centers within the network. We've got the National Frontier and Rural ATTC. We have the National American Indian and Alaskan Native ATTC, and the National Hispanic and Latino ATTC, and then finally the National SBIRT ATTC. So all of the promising practices and trying to address issues that are relevant to the field, the network tries very hard to make sure that these diversities are being addressed and that research that follows into practice, which can improve outcomes, are being addressed through the regional centers. Just a little bit about the organization that I work for, TASC. I am in a training department referred to as the Center for Health and Justice at TASC. We've been around for almost 35 years now, with our expertise being integrating justice and health services in Illinois. We kind of view ourselves as being the bridge between the criminal justice system, behavioral health treatment system, and recovery. Our primary work is rooted in case management, to keep people engaged in treatment and to improve the chance of successful recovery. And of course, our primary referral network is the criminal justice system. So at any time our staff are accountable to that system in reporting treatment progress, referrals to different treatment providers, that type of thing. And we've done a good amount of work with both county systems and the Illinois Department of Corrections, as well as some corrections systems around the country. So we feel we're pretty well versed in this topic. So that was just a little bit about TASC. Both the ATTC Network and the TASC organization have excellent websites with lots of information. So if you're interested in learning more about each network and organization, feel free to visit our website. So now we're going to go into our presentation a little bit. I wanted to give you a little background in terms of how I developed this outline. With the limited amount of time and the topic being what it is, I decided to really kind of look at the meat and potatoes, if you will, of reentry work. So I've kind of addressed a comprehensive reentry planning process with the things that we have learned become vital in terms of developing a good reentry program and maintaining good client engagement. Some of those things involve the timing of the reentry process with regard to, for instance, how much time a person is actually serving inside of a jail or an institution. We look at clinical case management, something that we think is extremely important in terms of how this case management process should look, starting with more a high-intensity type of case management and then stepping down, as you will see behavioral indicators would suggest that. Also looking at access to community services and support. As we move through the presentation, it will be pretty obvious that reentry work needs to focus on the community process and the resources that are in the community. Most clients can get through treatment in jail or prison with no problem, but once they are released, that's where the real test comes. So having access to services and support in the community is going to be vital to their success. And in doing so, we need to have tighter relationships between the clinical work and the community corrections aspect. For a long time, I think the systems kind of looked at themselves as silos, and the missions were different. But as you will see from some of the principles behind clinical reentry management, that our work needs to closely reflect that of community corrections and vice versa. Without going through too much of the principles, we're going to kind of go over them real quick, but what this presentation will illustrate is a step-down process, what something might look like. Again, these are merely examples. And I was very sensitive to understanding that people that are coming out of county jails, you may not have as much time to work with them. So as we go through this presentation, I'll have some comments around possibly what could be done with someone who is a short timer, for lack of a better phrase to put on it, but who may not be incarcerated for very long. Treatment phases and sentencing, again, the design around this had a lot to do with prison sentences, and so some of the challenges that come up are things like trying to calculate good time to make sure this person has enough time to actually get through treatment. So we'll talk a little bit about that. Also, to demonstrate the importance of pre- and post-release services. This kind of coordination of services is vital if you can obviously bring in community corrections into the institution or into the setting before the client is actually released, to start to establish that relationship and develop some rapport. We found that you have better outcomes when they transition to the community. We're going to talk a little bit about how to engage the family in the recovery planning process. And often, that goes beyond just adding a family member to a treatment plan, but actually understanding the different types of family therapy that's out there and what models that are available. Quite often, as we refer clients to treatment, they have unique issues which might dictate a different type of family involvement or family counseling. So we'll talk a little bit about those different family models. And then the importance of an interdisciplinary staffing, where you have both clinical staff and community corrections at the table together. Obviously, the reasons are it's not rocket science. You want the client to know that we're working as a team together, that their ability to play one end against the other is kind of diminished at that point when everyone is on the same page around what the plan, what the reentry plan, and the steps are all about. So those are our learning objectives for this presentation today. A couple of slides that I thought were critical. Back in 2007, NIDA released a publication that referred to the 13 best practice or best principles for reentry work. And I put up these couple of slides just as kind of a refresher. I'm sure many of you have seen these before. But they actually are the foundation for reentry programming as we know it today. First and foremost, understanding that the drug addiction or the substance use disorder is a brain disease that affects behavior. That is, very, very important concept to get your head around. And understanding that recovery from drug addiction requires effective treatment, not just treatment, but effective treatment, followed by the management of the problem over time. Again, going back to the disease concept, an addict has to deal with this disease for the remainder of their life. So it becomes not just a episode in time where they go through treatment and everything is fine, not kind of like an acute health disorder. But this is something that they're going to have to manage for the rest of their life. And so following that management principle over time, they need to develop strategies as their recovery gets stronger, that type of thing, to keep from going back to the active drug use. Treatment must last long enough to produce stable behavioral changes. Again, that's been a challenge across the country as funding problems have come in, programs have been cut. Like I say, I've been in treatment for a number of years now, and I remember where the average stay in treatment was 6 months. Now you're looking at, 30 days, maybe 90 days at best. So that is a challenge. Is that treatment lasting long enough to produce stable changes? And in doing so along that continuum, you're going to need to be very creative around how the treatment is prescribed. Whether it be a combination of inpatient and outpatient, that type of thing. So making sure that they have enough treatment is going to be very important. The next principle they talk about is assessment. That's the first step in the treatment process. And I think we've actually kind of even honed that skill a little bit to understand that there are multiple kinds of assessments. You have assessments that help diagnose the substance use disorder, In reentry management, now we're seeing more assessments around criminogenic risks and needs. What are going to be the triggers? What are going to be the types of things that the client is going to face upon release, and assessing what the risk factors are in those areas. So I think the assessment process is finally getting to the point where it should be, and it needs to be done over and over again, depending on where that client is in the recovery and treatment process. Tailoring services to fit the needs of the individual, I think that goes without saying. Most all of us have been trained around doing individualized treatment planning and service planning to making sure we're addressing what that client's actually going to need in order to be successful. Drug use during treatment should be carefully monitored. Again, your analysis budgets get cut sometimes, but there are other ways to look at, and monitor drug use during treatment. Again, clinical observation is probably the single most important monitor tool or skill a person can have. You kind of know when somebody has been using, and to be able to address that without fear of, maybe I'm making a mistake. But a urinalysis report can be manipulated, so we need to find other ways that are going to be that we're going to monitor that drug use during the treatment process. Treatment should target factors that are associated with criminal behavior. Again, going a little bit back to that assessment bullet, assessing for criminogenic risk and needs factors are going to be very important in addressing criminal behavior. One of the biggest challenges our clients face is, can they get a job once they get out of jail or prison now that they have a record? Again, that is a factor, that's a risk factor that could lead them back into drug use if it's not being addressed. So taking a look at those kind of issues are going to be very important. The other principles on here talks about criminal justice supervision should be incorporated into the treatment planning process. Again, I'm going to show you some concrete examples of how some reentry programs are doing this. The offender should be aware that providers are working with the corrections supervisors, and we are all on the same page around the direction the client should be going in and what their requirements are. The continuity of care is essential for the drug abuser in the reentry into the community, having the right match to treatment. That sounds very easy to say. It's often quite difficult, especially when your resources may be limited. But again, through case management and perhaps other supervision methods, that continuity of care can be maintained. A balance of rewards and sanctions that encourage pro-social behavior and treatment participation. A lot of programs are using motivational incentives, not motivational interviewing, but motivational incentives as part of their reentry process to kind of address that reward portion of it. It's often quite easy to come up with a long list of sanctions, but how do you reward good behavior? So there's a lot of different things that are going on in the field around voucher programs, and even just, giving someone a certificate. If a person has struggled with staying clean for the last 6 months, and now they managed to string 30 days of sobriety together, just recognizing that accomplishment is a very valuable reward for them. It helps build confidence and momentum toward recovery. Offenders with co-occurring drug abuse and mental health problems are often required as an integrated treatment approach. Well, as you all know, the healthcare reform is pushing us all toward that anyway. There are some strategies that I'll talk about with regard to jail-based clients where you might be able to leverage healthcare reform in keeping them engaged in the recovery process. And we'll talk a little bit about that as we move through the presentation. Medications are an important part of treatment for many drug-abusing offenders. This is a hot-button topic because you know what we're talking about. We're talking about things like methadone, Suboxone, naltrexone. Often that leaves it has a stigma to it attached that you're just substituting one drug for another. Again, I just kind of want to remind you that we're talking about a disease model of addiction. And if you had diabetes or asthma and your doctor prescribed medication in order to keep you stable, we wouldn't look at that as being a problem. We wouldn't look at that in a negative lens. We need to kind of evolve our thinking around drug addiction as well. For some addicts, medication may be an important part of their treatment process. That is certainly true when you're talking about co-occurring disorders. And then finally, they talk about treatment planning for drug-abusing offenders who are living in or reentering a community should include strategies to prevent, treat, serious chronic medical conditions. Again, I think our nation is moving toward a situation where that's going to be a little easier to manage with healthcare reform. There's going to be quite a few people who were eligible for any type of Medicaid coverage who will now become eligible. So then accessing medical care for chronic medical conditions hopefully will be a little easier. So again, those are the 13 NIDA principles that most reentry programs are using as they phase up their programs. So let's talk a little bit about this reentry planning process. Again, I'm describing a program, a reentry program, actually several reentry programs that I visited, and kind of outlining how they've designed their particular programs. And often at the top of the list or near the top of the list, they always talk about strength-based approaches. Quite often, you know, when we're doing assessments and we're intaking clients into a program, we're always looking at what the problem is. You know, what do they need, what don't they have, whether it's educational skills, no vocational skills, that type of thing. Well, reentry planning kind of switches the table a little bit in terms of looking at what does that client already bring to the table. Quite often clients in treatment come there with skills. They come there with probably some resilience, many of those that have been in and out of institutions before. And what we want to try to do is capture those strengths. We refer to it at TASC. We've got a little phrase we coined called recovery capital. So we want to look and see what capital do they already have so that we're not wasting time doing treatment planning around something that they already have a strength in. But a lot of reentry programs are using strength-based approaches. The other reason why this has been so successful is clients are often pretty beaten down when they get to the door. You know, and just kind of the old cognitive behavioral therapy, you know, the old CBT models of treatment, where you're breaking them down to a zero to build them up again. I wouldn't say it's not effective, but it certainly can't be the only cookie-cutter approach to treatment. So looking at strength-based approaches has been very successful and promising. There's a lot of research out there that shows that clients that are treated in such programs have very good outcomes. They talk about engagement and outreach oriented. What does that mean? Well, in the outline that I gave you before, we talked about pre- and post-release services. That's an attempt at doing some outreach into a community even before that client is released to the community. Quite a few programs are inviting in providers to come in and maybe do orientation sessions with clients who are in the final phase of their treatment, just to kind of let them know what services they have to offer in their community. So that outreach and engagement process is very important. It helps reduce the client's anxiety around moving to the next step. It's not unusual for clients who have been in residential treatment for a length of time to actually be kind of attached to that process. You know, might have a little bit of separation anxiety, if you will, knowing that they're about to move on. So having outreach-oriented processes to help them get adjusted and make that transition is very important. Another thing, they talk about ideal caseloads. Well, you know, there's a lot of research out there that says the ideal caseload is somewhere around 40 to 1. That might be a luxury for some programs. I know, especially when you're talking about probation caseloads and parole caseloads, that may not be possible. However, when using case management services, it becomes a little more doable when you can case manage a person, even though the probation officer or parole agent may have a very high caseload. If we can keep the case manager who's going to actually be monitoring their treatment progress, if we can keep those caseloads as you know, small as possible, it'll be helpful. It helps the client be able to connect with a member of that treatment team at the same time without feeling lost in the shuffle. But again, you know, this is an ideal situation. We know for a lot of programs and a lot of resources it may not be possible. Next, we talked about different phases of case management. And basically, I'm going to break it down into 3 case management phases, if you will. High intensity case management or regular case management, and then recovery support services. Again, in our 35 years of working with the criminal justice clients, we realized that clients at some point need to understand they're progressing through this continuum. Now, in the beginning, we talk about what we call stages of vulnerability. For instance, being released from a prison or from a jail back to the community is actually a juncture of vulnerability. Clients are often a little bit afraid. They may want to go home, but they're a little afraid of going back to the old people, places, and things. And so we always have our clients in that high-intensity case management for about 90 days, unless they're showing some behavioral indicators that would warrant stepping them down sooner. But we know that's a juncture of vulnerability for them, so high-intensity case management is very important in that initial release phase. And then once they have shown that they've made progress and, they haven't relapsed or complying with their community corrections guidelines, that type of thing, we step them down in the case management. Again, I'll show you some examples of what that looks like in terms of number of contacts and that type of thing. And then finally, after they've completed treatment, and they're pretty much on their own with their recovery, we put them into what we call recovery support services. Again, a lot of reentry programs around the country are using recovery support services as an adjunct to community supervision. It still allows the client to be connected with that recovery process, but at the same time understanding they don't need the level of services that they once did in the beginning. And it's kind of instilling a little bit of trust in terms of how they're going to manage their addiction once they're off supervision. So recovery support services has become an integral part of the reentry process. So again, ideally, if you can start this process somewhere around 60 or at least 30 days prior to a person being released, that would be ideal. And having a client staffed with various stakeholders, such as the treatment provider they're being referred to, the parole agent or probation officer they're going to be, supervised by, and, a reentry case manager who's kind of like that bridge between treatment and the criminal justice system. Starting those processes even before a client gets out is often proved to be very successful. Now, again, taking into account that clients who are serving a county jail sentence, you may not have the luxury of that much time. So the sooner that you can start processes like this, if you know that person is going to be referred to an aftercare provider, we can at least get part of that treatment team in or making contact with the client before they get released. That'll be helpful. And again, we understand that, sentences are doled out differently, and there's all kinds of different things that have to be taken into consideration. But starting that pre-release process, as we refer to it, is very important. And then ensures identifying services are being delivered. One of the things, and again, this may be, in the perfect world, but, quite often providers are just there to fill slots. And it's really incumbent upon somebody, and often it's the case manager, or it may be, the clinician of the treatment provider, to make sure that this is going to be a good match for that client. So we want to make sure that these needs that we've identified at that assessment phase are actually going to be getting the services they need to address those issues. So ideally, a reentry planning process involves all of these things. Now, again, just to give you kind of an overview of what high-intensity case management might look like, ideally, the first 90 days post-release is about right. Now, when you talk to people who are in recovery, and, you can even go to your local AA or NA meeting, and they'll tell you that, about 90 days clean is a red flag. That's when people start to feel pretty good about themselves. They may even, decide, let me test the waters one more time, that type of thing. Don't know if there's much science behind that, but people who are recovering will tell you that first 3 months out, the recovery, you start to feel good about yourself, and quite often people find themselves, exhibiting behavior that's risky, going around the old neighborhoods, that type of thing. So looking at this high-intensity case management for at least 3 months is a pretty good idea. It is also implemented at different junctures of vulnerability. So let me give you some more examples of what that might look like. My experience over the years as a counselor, probably one of the number one things that cause clients to relapse back to drug use is a failed relationship. Quite often when clients go through treatment, their outlook on life changes, and so does the outlook on life of their significant others or the people they were involved with. And so when you have a client who maybe is looking at having to break up with the girlfriend, or maybe she decided she wanted to break up with him, That is a juncture of vulnerability. This is a time where the client is going to need some talk therapy, how they're going to handle it. Is this going to be a trigger for that client, that type of thing. Now, there's many different junctures of vulnerability, and each one for each client is going to be different. Everything from losing a job, not having a stable place to live, or maybe they're living in a place that they don't, like being there. Maybe it's a dangerous situation for them in terms of their recovery. There's a lot of different opportunities for this vulnerability to step in. So in doing so, when you recognize something like this, ramping up that intensity case management may be necessary just to keep them on track. They're going to need a lot of support, basically, is what I'm saying. So it's designed to stabilize someone who's been incarcerated and probably hasn't had to worry about things. The pressures of just being out there on the street and on your own and everything can, be a lot of stressor, can be a huge stressor. So this high-intensity case management is really designed to help stabilize them as they reenter our community. And then formerly incarcerated persons are stepped down once you achieve some behavioral indicators. And this next slide will give you some ideas of what those might look like. So we talk about behavioral indicators for stepping down a person in case management. Things like stable housing, whether that be a recovery home or maybe they're in, independent living. Maybe they do have their own apartment or they acquire one. Engage in appropriate vocational programs or school. Doing something pro-social and positive. Stable in treatment. Are they complying with whatever their aftercare program is? Are they making their groups? Their analysis are clean, that type of thing. Have they found employment? Now, finding employment is one thing, keeping a job is another, but we do look at just getting employed as being a behavioral indicator they're headed in the right direction. And then there may be some work to be done around them keeping that job, because people get dissatisfied, especially when they think they're starting at the bottom, that type of thing. So encouraging them to stay engaged in employment is very important as well. 12-step support groups. I'm going to say something in putting my counselor hat on here. Probably, I don't think I know of any programs that do not encourage 12-step involvement following release and following completion of treatment. The people in AA and NA have known for years that one addict helping another or one alcoholic helping another is a very successful approach. And treatment programs are going to promote this in just about every model that I've ever seen. Quite often what will happen when a person gets back to a community, they think they're done. They've gone through treatment in this prison or in the jail, and they meet with their probation officer and parole agent, and they say, I finished treatment, I completed treatment. And that community corrections officer doesn't push the idea around 12-step recovery. I think it's a disservice to most clients. Now, I'm not such a stickler that I say everybody should go to NA or AA, but certainly some AA, whether it's the church A or CA or whatever. But 12-step support groups are very, very important for the continuum of recovery, because when you think about it, at some point, that person is going to exit our system. They're going to exit supervision, they're going to exit treatment, and they truly will be out there on their own. And if they have not developed themselves a network of recovering people, folks that are not using, that are not committing crimes, they're destined to eventually go back. So again, if you're not real big on 12-step recovery, at least act like it. I would encourage you to really push this, because treatment providers do it. And clients know that it's an expectation. They just can't wait to be able to tell somebody they're all done with treatment. The reality is they're not done with their disease. So again, that's just kind of my little soapbox on 12-step recovery. Complying with the community supervision guidelines, whether that's probation or parole, negative drug tests for the last 45 days, at least one test, 1 to 2 tests. These would all be behavioral indicators that a person is on the right track in recovery. And then maybe moving them from that high-intensity case management to more of the regular case management model would be appropriate. Again, it's important for clients to understand that they're making progress. And nothing speaks better to progress than saying, I don't need to see you 3 times a week now. You're doing pretty good, you got a job, that kind of thing. I'm going to move you in for maybe every other week or once a month or whatever your model is designed. But that lets the client know that, it's a vote of confidence that they're moving in the right direction. So having a step-down model and knowing that they don't need the kind of services they did in the beginning now, and we're instilling a little bit of trust in them and letting them take ownership for their recovery progress. So regular case management, what does that look like? Well, like I said, we started out with intense case management for around 90 days. So maybe for the next 90 days, they're in regular case management. Fewer contacts, implemented formally for incarcerated people who are stable in the community and are working toward achieving goals. You'll do that through your treatment planning, of course. And then formerly incarcerated individuals are stepped down in the recovery support services once other behavioral indicators are achieved. Now, we've tried a lot of different things at our agency with regard to putting timelines on stuff, and it was just to kind of guide staff along some direction in terms of, well, if the client has been working now for 6 or 8 months, and they haven't missed appointments and they've completed their aftercare and all that stuff, then maybe we can move them into recovery support. Again, it's a logical process. It doesn't mean that the client would never go back to intensive case management. And once you consider all those junctures of vulnerability, maybe they got fired from a job, and all of a sudden we need to be a little cautious about that, you know, and making sure there aren't some relapse signs or something that we're not paying attention to. So this is designed to be somewhat of a fluid system, but understanding we want to move a client toward recovery support. So in regular case management, give you some examples, clients, you know, at least 2 client contacts a month. One of those needs to be face-to-face. One of the things that gets overlooked a lot in our field, and I think it's an occupational hazard, is what your clinical observations are. You know, clients often can comply very well on paper, they know how to make appointments, that kind of thing, but if one day they walk in the office and they look a little disheveled and your hygiene's kind of fallen off, maybe you see something in their attitude that day, that type of thing, that clinical observation is telling you something. So that's why at least one face-to-face contact a month is essential. And then maybe another one could be by phone, something like that. Quarterly home visit. You know, again, this may not be something that you can do on a regular basis for every one of your clients, but certainly prioritize those who you feel might be at risk of relapse or be at risk of going back to criminal behavior, that there should be a home visit done. Now, in many systems where you have both case management services and community supervision, quite often that case manager will team up with the parole agent or probation officer to do that home visit. You know, that would be an ideal situation to be in, where you have a partner in that process, or at least communicate what you have observed if you did a home visit to the parole agent or the probation officer if there are some concerns there. And then, of course, having an interdisciplinary staffing, where your treatment provider, your community corrections, your case management person, and in some cases there may be other stakeholders that are willing to be a part of that process, such as an employer or a significant other. But having some kind of an interdisciplinary staffing at least once a month, you know, makes good sense in regular case management activities. So again, just kind of summarizing, you know, total it winds up being about 4 contacts per month, both in either face-to-face or by phone or some other method of contact. And again, paying attention to any junctures of vulnerability. And if none exist and everything are looking fine, then moving that client toward recovery support services would be the next logical step. Other things that we look at, behavioral indicators for stepping a person down. Have they completed all the required treatment? Again, just a reminder, the treatment they've done behind the walls is not all that they're supposed to be doing. Most providers, I think all providers, are going to have a referral to an aftercare provider when they get released to the community. Once that is completed, then you can say the treatment is completed. So, you know, looking at that as a behavioral indicator for step down is very important, making sure all the treatment is completed. Have they been employed for at least 60 days? Again, getting a job is one thing, keeping it is another. But after 60 days, you know, you kind of feel like, okay, maybe this person's on the right track, the job, and they're, you know, it's a good match for them, that type of thing. Negative drug tests for at least 60 days. Again, in the beginning we talked about having at least one in the first 30 to 45 days. So now, hopefully we've got 2, maybe 3. You know, again, if they've been clean, you know, that's a good indicator that possibly we can start looking at stepping them down. Stable housing for 60 days, that could be a recovery home. It could be, you know, with family. Maybe they've gotten their own place, that type of thing. Engaged in support groups. Again, kind of going back to my little soapbox speech, I don't care which one it is. You know, if they happen to find more comfort in faith-based type support, that's great. But if not that, there should be some support network in place. And quite often, and the most logical step is going to be some form of 12-step recovery, either CA, NA, AA, some A, whatever. And then, of course, complying with community supervision, be that probation or parole. So those are the indicators that this person may be ready to step out into a recovery support phase. Now, this is probably one that may last the longest, only because that first year out of treatment is so critical. So much happens in a recovering person's life once they've, you know, re-entered the community, gotten a job. I mean, they have a lot of things that they're working on. So recovery support shouldn't be any less than 6 months of that type of support to them. Again, it's not as intensive as case management, but at the same time, the client must feel connected to that recovery process. Hopefully by then, especially if they bought into 12-step recovery, you're going to see behavioral indicators that show that they're really buying into this recovery process. Quite often, they're still on the honeymoon. They're still feeling pretty good about being clean and sober, you know, and that's great. We want to leverage that enthusiasm and motivation. So we want to look for things where support, you know, for the individual's ongoing and recovery. The primary worker assigned to working with this client is going to be a recovery support specialist, and not so much the parole agent or a treatment provider anymore. Certainly keeping those connections open, but the person that they're going to be having a lot of contact with at this point will be a recovery support specialist, if you will. That's the title that we have for a position here at TASC. Continues ideally for around 6 months. So by now we're talking about a year. 6 months of treatment has been prescribed and completed, and good 6 months of recovery support has been in place. And then that 6 months of recovery should indicate all kinds of things in terms of the client moving in the right direction, and the recovery is starting to gain foot. Now, again, you talk to a lot of clinicians and practitioners, they'll tell you the 1 year mark is something you got to watch out for. By then, the clients have gained quite a bit of confidence and might even get a little cocky with their recovery. So even though they may be doing great, be mindful that 1 year clean and sober is a milestone. You know, even the recovery meetings that you go to, you know, they make a big deal out of getting that 1 year clean chip. And for a lot of times, that can be a scary proposition because the longer they stay clean, the higher the expectations are on them. You know, and this is about the people that are around them are starting to expect better behavior out of them. So that can be a very scary proposition and sometimes wind up leading to a period where they become vulnerable again. So monthly activities and recovery support, what might that look like? Again, maybe recovery check-ins by phone. You know, they're no longer required to come and see a treatment provider. Now, obviously, the community corrections people will still have requirements in terms of monthly visits. But as far as the recovery process and how they're connected to the treatment part of it, those check-ins can be done by phone. Monthly contact with the parole agent or probation officer, where we're going to share and coordinate pro-social recovery activities. There's a lot of, this is especially true in larger metropolitan areas, but the recovery communities can be quite large. You know, you see all kinds of activities that they sponsor, everything from softball games in the summer, just lots of things, bowling, all that kind of stuff. And understanding and knowing about some of those activities is a helpful tool, because if the client doesn't know how to relax and enjoy themselves, they're going to think getting clean and sober is just boring. So it might not be a bad idea to avail yourself of what activities are going on in the recovery community in your area. And then continue monitoring support group attendance and getting a sponsor. This is another thing that often gets overlooked, especially in the supervision world. But if you're going to be involved in a 12-step recovery process, it is required that you get a sponsor, okay? A sponsor is going to be that person who is their mentor in the program. Now, most people that buy into the 12-step models, they take their time about getting a sponsor. They actually want to try to choose somebody they like or they think likes them, that type of thing. That's fine. The point being, as long as you get one, because if you get a sponsor and that person's not working out for you, you can always get another one. But it's important not to underplay the importance of sponsorship in these 12-step programs. Again, this is a move toward independence. This is a move toward ownership of your recovery and being able to develop trust in someone who's going to help you. So again, just as part of that whole 12-step model, always ask them about, do you have a sponsor yet? You know, especially after they've been going to meetings a few months, because by then they should have connected with somebody. Again, I apologize for this slide. The font got very small. Just to kind of go over what a successful completion criteria might be, and we're talking about treatment only, not necessarily the entire supervision process, but completing all treatment, establishing stable employment or income. I would say income because some clients are going to be in situations where they may not be able to hold a job, but if they're eligible for SSI or some other benefit or whatever where their income is stable, we consider that to be a completion or a success completion. Stable housing for at least 60 days, no substance use in the last 6 months as evidenced by negative urinalysis and other behavioral indicators. Positive support system, and again, that's a generic term. It can be faith-based, it can be 12-step. Maybe they just have a really large family and everybody is supportive. That's fine too, but having that engagement is what counts. And then 6 months case management and 6 months in recovery support services. At our agency, we kind of look at these indicators that they completed all these things, and they get discharged successfully from TASC. They may still be on probation or parole for another, 6 months, maybe a year or whatever. The important part of this for the clinical aspect is that the client knows that they've made progress, and they've been, and that's being acknowledged. They start treatment because they actually want to finish treatment. So it's kind of a disservice to keep them in a process for as long as they're on probation or parole, for instance, unless it's warranted. So them being able to actually complete treatment is kind of like the benchmark, and it's their license to give back. At that point, they should be engaged themselves in trying to help someone else. And that's kind of what the whole recovery process is about. So these, again, are just some examples of successful completion criteria. Just a few things to kind of go over in terms of maybe some challenges that you may face. Again, where prisons are concerned, I'm not sure how it is around the rest of the country, but I think a lot of states have good time or earned income credit time, some other label where it indicates they're getting credit for time they served maybe in the county jail while waiting trial. Or they participated in a behavioral program that gives them a good time or they earn a good time. So understanding how to calculate those things are very important, especially at the front end. We want clients to be able to be engaged enough in the treatment process, whatever your treatment model is, so that they can complete it and get the full benefit. So that's one challenge. The length of time of the treatment model. There's a lot of research. If you visit the National Institute of Drug Addiction and also look at those NIDA principles, there's a lot of research that says keeping a client in treatment too long is counterproductive. So the timing is important. At some point, the phases of your treatment need to almost complement the sentence in a way that they are being phased down or put in the phases as is appropriate for the reentry planning process. Transfers from general population when the time is optimal. Just to kind of give you an example, here in Illinois, we had a number of clients whose sentences were rather long, where they were serving 5 and 6 years of real time, but they still wanted to sign up for treatment. And so we had to set up a process and a system within our Illinois Department of Corrections where when they got within 36 months of release, they could be transferred into the treatment program if they still wanted to. That way they would not be just kind of recycled through treatment while they're serving the entire prison sentence. So if you have the option or the luxury of being able to transfer from general population when the time is right, being able to do that would really help out. Avoid sending inmates back after they finish treatment. Again, the same works on the reverse. If you get them in treatment too early and their sentence is too long, what do you do with them when they finish treatment? You don't want to keep them in there forever. Obviously, you want to open up a slot to the next client. So you want to try to avoid situations where you're transferring them back, because that's backward progress, not forward progress, as far as the clients are concerned. So having the timing of treatment with the sentence is very important. And again, being sensitive to jail populations where you probably are not going to have a lot of time, period, you're going to have to kind of switch gears in terms of maybe just implementing the reentry planning process first, because that client's only going to be in custody for 30 days. So that means engaging that community aspect first, as opposed to being worried about getting them through a phase of treatment. So it will depend on what your system is set up like and how much time you have. And again, just as a rule, treatment should be near the back end of the sentence as possible. Again, working on reentry planning is kind of the emphasis of it. When they go into treatment, that treatment is timed with their release so that they complete those phases and they go into reentry planning. So timing of treatment is an important challenge, I realize, for a lot of systems. Access to community services and support. Again, I just kind of want to leverage the conversation around healthcare reform. There may be a lot of providers who at one time were not interested in working with corrections clients unless there was funding attached. Well, healthcare reform hopefully will broaden that funding stream, because basically that's what it's going to be, is a new funding stream, where they may not be relying just solely on single state agency funds, where they might be able to leverage Medicaid funds. So hopefully being able to access community services and support will become an easier nut to crack over time. And again, I believe healthcare reform is going to be a huge leverage for that. What types of community support are in your area? Quite often when you're talking about rural parts of a county or a state, rather, there may not be a lot of services there, and we have to think creatively around how do we fill those gaps. Again, 12-step recovery, faith-based organizations have done an excellent job of filling gaps in those areas, and engaging those people in the process of planning reentry is going to be vital in those kind of rural areas. So those are some things you want to consider as well. How to engage the family. I want to talk just a couple of minutes about some family therapy structures. We often focus so much on treatment these days around substance abuse treatment, we forget there are different models of family planning and family recovery processes. The primary goal of most family treatment is to educate them on substance abuse disorders. I'm sure you know that quite often a lot of family members wind up becoming part of the problem. They're enablers. They may be in denial themselves that this problem is even affecting their family and they don't want to deal with it. So educating them on the substance use disorders is very important for the family. Sharing the treatment planning process. It's not unusual for clients to kind of like not be real forthcoming about what they have to do in terms of their aftercare. Well, that family, those significant others, the wives, the mothers, the fathers, need to be a part of that treatment planning process so that they know what the expectations are. Contingency management. We often talk about this in the context of doing some behavioral contracting with the client, but believe it or not, contingency management can be extended to the family as well. To give you a quick for instance, say you have a client who no longer has a driver's license and can't get to aftercare treatment. Well, believe it or not, doing some contingency management with, say, an aunt or an uncle who's willing to drive them and actually do a behavioral contract on paper, where there's a commitment, that type of thing. That's a huge therapeutic tool for getting clients to understand that their family or this person really does want the best for them, and they're willing to put their name down on a piece of paper and give them a ride to treatment as often as needed. So using these kinds of tools in contingency management could be very valuable in leveraging that client's motivation. Understanding of the different therapy models, I'm going to go over just a few real quick because we are running short on time, but I wanted to give you some idea of what family therapy really looks like. You got a family model that's based on what most treatment programs base their models on, and that is the disease model. There's a family disease model that looks at substance abuse as a disease that infects the entire family. We know that to be true because quite often the family people are the ones that the client is abused first, whether it be just emotionally, financially, that type of thing. So they need treatment as well. They need to repair themselves from this process. Limited controlled research, there's not a lot of evidence out there that says family disease models work any more effectively than any other. But understanding that the family has been affected by the substance abuser's behavior is what's most important here, and they need education. The other thing that I will tell you about this disease model is there's nothing worse for a client who feels that they really applied themselves in treatment and doing everything they're supposed to be doing, they're complying with probation, with parole and everything, and the family treats them like they did before they went to treatment. It's very deflating. At some point, the family needs to understand that they need to make progress too in terms of forgiving that client, maybe instilling some trust in that client again, that type of thing. So the disease model will focus in on those kind of aspects. It's the same kind of behavioral modification that clients would go through in a CBT program. Then we have the family systems model. This is based on the idea that families become organized by their interactions around substance abuse. How often have you heard, where the person gets high with their dad or their mom, that type of thing. So they're adapting to substance abuse as it's possible for the family to maintain balances, and drawing the line. If they know that person's supposed to be in recovery, that maybe alcohol is no longer permitted in the house. Now, obviously, if the person has no problem with drinking, that shouldn't be too much of a stretch. So the family systems model is centered around the family coming together and with a common goal to help support recovery. Another model is the cognitive behavioral approaches based on the idea that maladaptive behaviors, including substance use and abuse, are reinforced through family interactions. Again, how often do we have families where there are other people getting high in the family, whether it's a sibling or a significant other, that type of thing. Those cognitive behavioral approaches need to be addressed, where maybe not only that client has gone into treatment, but we might need to encourage that significant other to enter treatment too in the best interest of both. Another is the multidimensional family therapy. This is, I wouldn't say a fairly new approach, but the MDFT approach has integrated several different techniques from the models that I previously showed you, but it's very strong on the emotional context, understanding how clients feel about stuff. There are a number of trainings out there, especially for criminal justice professionals around criminal thinking, where it talks about attitudes, beliefs, that type of thing. Well, the multidimensional family therapy is centered around thinking and attitudes and beliefs. This can be a very strong motivator in terms of whether or not a client is actually going to make that transition into recovery or not. If their entire generation in their family has been brought up a certain way, that's going to be a very difficult thing to combat if that behavior was negative or those family relationships were negative. So the multidimensional family therapy would involve not only treating the client, but other people who are significant in that client's life. And it involves all kinds of things. It has environmental input, emotional aspects, as well as cognitive and other behavioral approaches. So these are some, if you want to read up, obviously there's plenty of literature on all of these models of family models of family therapy, but I would encourage you to do so. Quite often we just say, the client's going to be involved in or the family's going to be involved in the client's treatment without really knowing what that means. So understanding what different family models are out there will help you get a better understanding of what that treatment would look like. As we near the end of this, I want to just kind of emphasize the tightening of the clinical and community corrections relationship. And in doing that, we want to try to develop activities that involve both as part of the clinical team. Whether or not a parole agent has ever been invited to a clinical staffing, if that's never happened, it should start, and vice versa. Maybe the parole agent should invite the counselor or the case manager to the next session that the client has with them in the corrections office, be it probation or parole. Do pre-release staffing. Again, if you have the luxury of having these community corrections partners come inside the institution prior to the person being released to make contact, that would be ideal. Again, it helps reduce the anxiety the client goes through when they get a chance to maybe meet who their probation or parole agent is going to be before they even get released. They can actually start establishing that rapport. Again, the community corrections person can meet that person's primary counselor and develop these kinds of relationships that would complement the continuum of treatment. And then making compliance with corrections, with community corrections, an integral part of the treatment planning process. Again, knowing whether or not that person is going to be on a particular type of supervision and what the conditions are should be included in the treatment planning process. It's not a separate event in time or anything. This is part of your recovery. So being on the same page and supporting both that community corrections requirement as well as what the treatment requirements are. And then immersion training. We spent a ton of money here in Illinois bringing parole agents into therapeutic treatment for about 3 days just so that they would understand what a treatment group looked like. So the next time the client says, oh yeah, I went through treatment at such and such a prison, they actually knew what that meant. So if you have the opportunity to do any kind of immersion or cross-training of both your clinical staff and your community corrections people, I would encourage you to do that. And then work in tandem, again, supporting each other's mission. Understanding what community corrections is, their number one thing is going to be public safety, and they need to understand that maybe you as a clinician, the number one thing for you is making sure that client doesn't, use drugs or alcohol again and stays crime-free. So working in tandem and supporting each other's mission is crucial in this process. Well, that concludes all my slides. I hope I left enough time for questions. I realize this was a rather short webinar. We were trying to cram a lot of information in. But at this point, Katie, I guess I will turn it back over to you to handle any questions you may have put together, and I'll do my best to answer them.
Great. Thank you so much. We really appreciate it. I think that was a really great foundation of information on creating some of these connections to the community. So really appreciate that. We do have some questions that are coming in. Before I go ahead and sort of start with the ones that we've received so far, I just want to provide a reminder to the audience that you can ask a question by typing it into the Q&A panel on the bottom right-hand portion of your screen, and then we'll be able to ask those and hopefully get to all of them, and if not, we can always follow up. We received some questions about your comments regarding the Affordable Care Act, and just wondering if maybe you can elaborate a little bit more about what some of those implications might be for people that are coming out of incarceration with substance abuse issues in states that do choose to expand Medicaid.
Okay. Well, I can definitely speak to what's going on here in Illinois, but I would almost guess that it's going to look the same in other states. One of the things that we've started here in Illinois is we're actually starting to screen clients for eligibility. The Affordable Care Act is not a very difficult criteria at all. It has to do with residency, where that person lives. Let me see, income level, and one other thing, residency, income level, and there's a third thing, but it's really so minute, it slips my mind. But anyway, if they meet residency requirements, which means U.S. citizen, live in this county, whatever, they are eligible. What this is doing for a lot of clients, for instance, a male client who has no children that they claim as dependents, in the past were not eligible for Medicaid-type benefits. They couldn't get a medical card. They might be able to get food stamps, but that was just about it. Under the new Health Care Reform Act, that Medicaid health coverage is expanded to those individuals. And so what we're doing here in Illinois is we're looking at pretty low-level offenders, people that would have what we call Class 4 felonies, which might be a drug case or a theft case or something like that. where we know they're not going to be incarcerated for very long. While they're incarcerated, they're not eligible for benefits. But once they're released to the community, we want to establish that linkage as early as possible to their local Medicaid office so that they can complete their application. This would provide funding for treatment. If that client needs to be referred to substance abuse treatment in the past, like here in Illinois, we'd have to rely on our single state agency funds, which, as you know, can get very limited, especially mid-year through a budget year. Now that we have the government sequester, it's even been more critical. But if that client can be referred and they now have a Medicaid card that helps pay for their treatment, that's going to increase the number of clients that will have access to those services. I hope that kind of answers the question.
Great, thank you. We received a lot of questions when you were discussing the recovery support specialist position. And so I think, in sum, if you want to talk a little bit about what makes someone qualified for this position, what this position looks like, and maybe a few more words on sort of what they're able to do as a result of being in that position.
Okay. And I'll tell you a little bit about how we've operationalized it, not only at TASC, but we've seen this at other treatment providers across the state. You have a new professional wanting to come into the field of substance abuse counseling, and one of the things they have to do in terms of being certified, at least in Illinois, is they have to put together 2,000 hours of direct service. In other words, they have to be employed. So quite often we are permitted by our state to hire that individual with the understanding that within 2 years they're going to meet the training requirements and 2,000 hours of direct service to become a full-fledged certified counselor. So in doing that, we decided to leverage those resources in what we call recovery support services. This is an opportunity for them to get their feet wet, to kind of understand what the lay of the land is going to look like in terms of treatment. They're doing case management work. They're meeting directly with that client on, a pre-prescribed basis. But their primary job is to just make sure that that client is engaged in recovery. They're not necessarily writing treatment plans. However, they may be in contact with a primary counselor who does have a treatment plan written, and that recovery support specialist becomes part of that support network. So it's a milieu tech, I guess, is one way of describing it. A quasi-professional treatment person whose primary focus is on making sure that the client is engaged in recovery processes, whether that be 12-step recovery, could be faith-based. They're kind of like the third person on the team there that's always, kind of encouraging that client to stay on the right track. That's how we've implemented it here. Now, there are a couple of organizations, national organizations. The Faces and Voices of Recovery is one. And then we have one called the National Recovery Ambassadors. These are community organizations that actually have training programs and workshops for people who want to work in recovery support, where they don't necessarily want to be a treatment provider or anything, but they want to be a part of the recovery support process. It's almost like an advocacy, a community advocacy type program. So I would encourage people to seek out Faces and Voices of Recovery and just Google the term Recovery Ambassadors, and you'll find your way to those organizations as well.
Great, thank you. We received some questions when you were discussing the medications that are sometimes used to assist with treatment, and wondering if you can elaborate on that a little bit in terms of perhaps some of the medications that are available, but also sort of in general some of the benefits of medication-assisted treatment.
Sure. Well, I'll tell you right off the top that most of the medications that are available are very expensive. When you talk about Suboxone, it's almost cost prohibitive in a lot of ways. And the reason why medicated-assisted treatment has become such a focus on reentry is because they have to try to figure out ways to subsidize the cost of medication. And at the same time, a lot of people don't like hearing this, but one of the most effective medications for opiate addiction is still methadone. I worked at a methadone clinic. That was my first job as a counselor, and I can tell you when it's coupled with clinical work, in other words, group therapy, individual sessions, and everything that's monitored closely, methadone can be a very effective tool for opiate addicts. There's some other research that's going on out there regarding other kinds of medications for other types of substances, but primarily Suboxone, naltrexone, those drugs are centered around opiate addiction. The reason why that's so important is because opiate addiction doesn't necessarily mean a person is strung out on heroin. As a matter of fact, there's an alarming number of people that are addicted to pain medications, the OxyContin, those types of drugs, because they actually have a legitimate pain issue that is turned into an addiction problem. And so, the drug companies are trying to combat that, but unfortunately, and, it kind of rubs me the wrong way when you consider the fact that, we're out here trying to help people, but yet the medication costs so much they can't afford to be helped. That's a problem. But I will say that, I've been to a number of workshops and a number of conferences recently where you actually have pharmaceutical companies there speaking and making some strides in terms of making medication available to clients who need it, who might not otherwise be able to afford it. And again, there's a number of studies. I know Texas Christian University has got a study going where they're doing some medicated-assisted treatment, giving clients Suboxone prior to them being released from prison, just to keep them from going back and relapsing on opiate drugs. So there's a lot of focus on this. It's just, it's one of those things that is developing over time. But medicated-assisted treatment is necessary for some clients. I'll give you one real quick example, and then we can go on to the next question. I had a client who was in his late 50s who was a chronic asthmatic, who had been on methadone at our clinic for about 2 years. And he started a very high dose because he was, a heavy heroin addict for a number of years. Every time we took or tried to detox him and take him off of methadone, and he wanted to get off of methadone, it would exacerbate his asthmatic condition, almost to a life-threatening kind of situation. What happened was, through his physician and our clinic doctor, they managed to get him into a phase of maintenance where he wasn't feeling the effect of being on methadone, but at the same time it was also helping him control his asthma. The doctors felt that this individual would probably need to be on methadone for the remainder of his life as long as he didn't relapse back into opiate addiction. And that client managed pretty well. I mean, once he accepted the term that this is another medication that I have to take for my asthma, even though it had to do with my heroin addiction, that was something that he finally accepted. So those are the kind of situations where I'm saying it may be medically necessary for medication to be a part of the treatment plan.
Great, thank you. And I do want to mention to the audience as well that through the Second Chance Act, we work with a few programs that are specifically utilizing medicated-assisted treatment. And so one of the next few slides will have my contact information on it, and you're welcome to reach out to me, and I can put you in touch with those groups as well if you want to have some additional conversations. So we've received a lot of questions about working with jail populations, in particular with a short stay, and wondering if you wouldn't mind elaborating a little bit about maybe sort of the really important things that need to be done if you only have maybe 1 to 2 meetings with the client while they're incarcerated, and sort of what is really key to focus on and key to get done in that time and make sure that you have accomplished.
Well, it's a big challenge because often when clients are in that jail setting, it may indicate that this may be the beginning of their criminal career, where they're not there for very long, or maybe this is their first or second arrest, that type of thing. So quite often the focus needs to be on, just kind of quickly assessing whether or not a substance abuse problem is connected to the reason they're behind bars. And if so, about the best you can do in that short time frame is to give that client some resources in their community within the context of where they live that they can reach out for help. This is always going to be a personal choice for the client whether or not they want the help. But if you get a client who's, bouncing in and out of jail and stuff, quite often that might mean they're, just now starting to feel the consequences of their substance abuse, and early intervention is needed. So that would be my primary focus, just educating them, not necessarily trying to convince them they have a problem, but letting them know that once they've figured out they have a problem, here's where you go to get some help. That would be the number one thing. The second thing that I would think about would be just kind of helping them play the tape all the way through. I do the training, like I say, on criminal thinking, and one of the bigger sessions in that has to do with what's called the lack of time perspective. In other words, it's a fancy way of saying they don't remember the last time they got locked up and what happened, but yet they've done the exact same thing again. So they're not learning from their past experience, and they're not thinking far enough ahead to know that they're headed right back down that road. So I spent a little time with them just kind of maybe going over their rap sheet and say, this is the third time you've been arrested for possession of a controlled substance. What's that telling you? Using some motivational interviewing techniques to engage them in a conversation to help them paint the picture for themselves. So education and maybe a little reflective listening would be the two things I'd focus in on short-term stays like that.
Great. We got a question and would like to sort of preempt this by mentioning to the audience that, this is the first part of a 5-part webinar series, and it is our intention that the final webinar will concentrate specifically on relationships with community supervision. But we did receive a question that I think, is important to sort of touch on now. We received a question sort of about working with community supervision with the dual goals of recovery as well as reducing recidivism, and was wondering if you could talk a little bit about how relapse plays into that and sort of what that relationship with community supervision can look like and sort of that communication around a relapse during the recovery process.
Well, if I think I understand it right, this goes back to one of the cliches that they always talk about in 12-step recovery and the things that clients have to watch out for, people, places, and things. From the community supervision part, it's really important for the community corrections person to know who those people, places, and things were that got that client in trouble. And really, unless that person is surgically attached to them at the hip, the minute that corrections officer sees them kind of going down that road, they need to put them in check quick. These are those little subtleties that happen in recovery. And, it can be kind of a sticky situation because maybe that negative person in that client's life happens to be a relative. But what's important for the relationship between community corrections and the client is that the corrections person knows about it. And it says, hey, I'm not telling you what to do or, you got to go divorce your wife or any of that stuff, but I'm aware that this has been a problem for you in the past. The more times you can get clients to understand that you know what their MO is, the easier it becomes for them to start to address it because they feel like they have some support. There's nothing worse than going home and thinking nobody understands what your problem is. So when you're talking about relapse and understanding that relationships, and I mentioned it before, relationships is probably the number one key factor that lead to clients relapsing, on drugs and then eventually probably going back to a life of crime. Relationships becomes vital in terms of what the community corrections people need to focus on. Does this client have any positive relationships going on? And if not, how can we help foster some? And again, I put my emphasis back on 12-step recovery. If that client really doesn't have anybody positive in their life, encourage them, drive them to a meeting if you have to, that kind of thing, just to get them engaged. It's been my experience over the years that once clients start going to meetings, especially if they have some concern about where they're going in the future, once they start going to meetings, they will find some comfort in that room. Because there's going to be other people there who've been through just what they're going through and probably have the same kind of attitude in the whole 9 yards and somehow managed to make it. And that will be an important revelation for the client. So, that's pretty much what I have to say about it. Just don't ignore the 12-step recovery process because clients are not going to be able to do this on their own.
Okay, thank you. I think in the interest of time, that's probably going to be the last question that we get to today. But do want to let everybody know that if you have additional questions regarding content that was discussed today, if you think of additional questions or didn't have yours answered today, you can feel free to reach out to me at the email address you see on the screen, and I can connect with Phillip as well as provide some additional resources at your request if you want to go ahead and email me with any of those questions.
And Katie, it's okay to share by email everyone if you want. If you do get questions in, just, give them my email or forward it to me. I'll be more than happy to connect with them.
Wonderful. Thank you. As you can see on your screen, there are some selected ATTC resources that are pertinent to today's webinar that you'll be able to look at. We are going to be making these slides available on the National Reentry Resource Center website, as well as the recording of the webinar will be available early next week, so you'll be able to have access to some of these slides as well. This concludes today's webinar. After you exit the webinar, a brief survey will appear on the screen. By answering the questions in the survey, you'll be helping the Resource Center improve on the services we offer. So we'd greatly appreciate it if you would just take a few minutes to complete the survey and provide some of your feedback. As I mentioned, we will email a link to the recording of this presentation as well as a link to the PDF of the PowerPoint slides used. These links will be made available on the National Reentry Resource Center's website that you can see on the screen. And I also encourage you to sign up for our newsletter as well, which will have additional webinar opportunities available. I'd like to thank Mr. Barbour again for the great discussion today, as well as the Addiction Technology Transfer Center Network, TASC, and the Bureau of Justice Assistance for their partnership on today's webinar. We really appreciate everyone's participation today and look forward to having you on another webinar soon. Thank you.
Thank you for having me, Katie.